Next speaker, Dr. Deepesh Kalra. He will be speaking on role of FANS in present era in flexible ureteroscopy.
Good morning, all the teachers, my seniors, and my dear colleagues. So, the question is, can fans be a real game changer in today's scenario? So, whenever a patient walks into our OPD, what are his or her expectations? That a procedure should be minimally invasive or non-invasive at all. There should be no morbidity at all. The stone should be completely cleared. It should be a one-stage daycare procedures, and stone should never come back. But what are the harsh reality we face as RIRS surgeons? In flexor registry, it is shown that the residual fragments rate is 21.7% still, and sepsis is still there in 0.5 to 11% of the cases, which is not very huge, but is still a very notable number. Most common cause of increased sepsis is intrarenal pressure. Normal intrarenal pressure is less than 15 centimeter S2O. So what happens when this intrarenal pressure increases beyond this limit? A pylorenal backflow starts happening in the form of pilotubular, pilointerstitial, pilovenous, and pylolymphatic backflows, and which in turn can give rise to increased sepsis complication. When we are using irrigation in ureter, and if we are using flow of more than 6 ml per minute, it acts like an open tube. That means the flow and the pressure is in linear relationship. So apart from pressure, there is one more notable component is intrarenal temperature. When we are using laser in the pelvis, if we are using 20 hertz, only 52% of the emitted pulses are reaching the stone. And if we increase this frequency to 80 hertz, only 4% of the emitted pulses are reaching the stone. Comparative study between high and low power lasers show that high power lasers use significantly lesser operative time, but significantly higher joules per millimeter cube. So what is happening with all this extra energy? Tissue and cell damage, which starts happening after 240 minutes if the temperature is 43 degrees centigrade. But if this temperature is increased to 53 degrees centigrade by only 10 degrees centigrade, this damage starts happening after 15 seconds only. This we all have faced in our practices. The snowstorm or snow globe effect. Whenever this dust particles comes and hamper our vision, we have to do intermittent dusting, the kind of pedal on, pedal off, and then that dust settles on, and then we can continue our surgery. So what are the Achilles heel of RIRS right now? We have poor vision, intrarenal pressure, increased intrarenal temperature, and residual calculi. So how can we try and deal with this? If we increase irrigation, we'll have better vision, we'll have temperature control, but the pressure will increase and then it can give rise to sepsis complications. By decreasing irrigation, the pressure will decrease, but then our vision will not improve, and then temperature will increase. But by increasing outflow, we can have better vision, better intrarenal pressure and temperature control. So the bridge between reality and a dream is work. And a tremendous amount of work has been done in the field of RIRS, most notably in the form of development of access sheaths and development of different sections. So it has been reported that suction access sheaths have a strong potential to improve stone-free rates as well as minimize the complication. So any game-changing technology in the field of RIRS should improve the stone-free rates, minimize the complications, and should reduce the re-intervention rates. And one most notable innovation is fans. So is suction is the future of endourology? It might be, yes, because the advantages are better intrarenal pressure control, better intrarenal temperature control, better visibility, shorter operative time, better stone-free clearance, and even pushing our procedural limits. But disadvantages being operational complexity because of the longer access sheath and undefined suction parameters. So many studies shows the suction access sheath versus normal ureter access sheath, the better stone-free rate with the suction access sheath. There are at least 21 papers which talk about different modes of suction. We can use suction via access sheath. The access sheath can be bendable or non-bendable. We can use it via a scope in the form of disc, direct intra-scope suction, or it can be modified scope, the MIST technology, which was developed by Dr. Parimal Gharia. But still, balance was in favor of PCNL because we haven't achieved on-table clearance yet. We always talk about multiple procedure 2 or 3 times we have to do the RIRS. So our goal is to have better vision, better intrarenal pressure and temperature control, and have on-table clearance. And to achieve better control, we should avoid the interference of UPJ in controlling intrarenal pressure. How can we do that? By bendable access sheaths, which can cross the PUJ without injuring it. So here comes fans, flexible and navigable access sheath, which compose of a sheath which is 50 centimeter in length and suction component. This sheath can be bent with the help of our RIRS scope at least 90 to 100 degree. So tip bendable suction neutral access sheath versus routine access sheath, multiple studies are there which show better immediate stone-free rates, better 3 months stone-free rates, lesser chances of basket use, and lesser sepsis complications. A study by Dr. Vineet Gohar shows the 10 by 12 French access sheath is better than 11 by 13 French access sheath in suctioning, maybe because of better vacuum clearing effect, and there was no difference in infectious complication. To maintain safe intrarenal pressure, the crux is the ratio of endoscope to sheath ratio should be less than 0.75. So what are the indications where we can and we are using fans for? Obviously, pre-stented patient, as ureter is already dilated, ureter is already accommodable, we can easily do fans in these kind of cases. If we are doing check or relook RIRS, the fragments, usually the fragments are very small, basketing becomes very tedious. Sometimes the stones fragments are not even basketable. In those cases, we can do RIRS as patient is always already stented and ureter is very accommodable. In pre-stented cases, So on-table clearance. The on-table clearance in RIRS is now a reality. If we can see through RIRS, through fans, we can suck all the dust very easily. Even the smaller fragments are being sucked into the access sheath very easily, and we can achieve this look after RIRS. This was a case where 1.8 centimeter stone was present in middle calyx. So in larger stones, we can very well do RIRS with fans and achieve on-table clearance. Matrix stones, initially RIRS was not possible because of increased chances of sepsis and inability to remove the matrix component. But with advent of fan sheath and suction, we can reach to the matrix part and suck it out in the access sheath. If some parts of matrix are not being able to suck out, we can always use our baskets and we can achieve on-table clearance without increasing the risk of sepsis. So tubeless RIRS. If a patient is already stented and now we have done RIRS in that patient and we have achieved the on-table clearance, the now concept has come that there is no need to stent that patient and we might be moving towards not putting Foley's at all also. In bilateral surgery, if patient is pre-stented, if we want to achieve on-table clearance in one go, we might be able to do fans. In CKD and small kidneys, previously RIRS was reserved because of chances of increased sepsis, inability to remove all the fragments, and in smaller kidneys, increased irrigation, increased intrarenal pressure can give rise to the rupture. But fans solves this. Hydronephrotic kidneys, the PCNL was always the first choice procedure because of ease of access, less bleeding, and inability of RIRS to remove all the smaller fragments from the dilated roomy calyces. But fans solves this too. In multiple secondary calculi, this can be 10s to 50s to 100s in numbers. If the fans is reaching the mouth of the particular calyx, we can remove all the stone in one go and we can reduce the basketing significantly. In diverticular stone also, if fan reaches the mouth of the diverticula, we can achieve on-table clearance. In large impacted ureteric stones, the problem is how to safely use laser in those cases. If we are using fans, the vision will be much better, so we can use the laser very safely and the temperature control also will be very good. So what are the concerns with RIRS we can have? The scope maneuverability obviously will not be as good as without the sheath. The scope durability might decrease because we have to bend the sheath with the help of scope itself. The longer length access sheath might be a bit cumbersome to use. Strain at PUJ, still there is no data supporting the use of, no data supports that use of fans can increase the risk of injury at PUJ. So we can use fans safely at PUJ. There are chances of mucosal bleed if we suck it out uncontrollably because of there is no standard pressure guidelines yet. So we should always start with pressure as low as possible. And assistance. We might need one more assistant to assist us than usual RIRS cases. So if a technique or technological innovation significantly help in changing the way surgical procedure is done, it can be a game-changing procedure. But if it becomes a measure of excellence that can be universally replicated, it can be a gold standard. So could use of fans be a game changer? The answer is yes, because of better stone-free rate, minimizing complications, and achieving on-table clearance. Thank you.
Thank you, Dr. Deepesh, for your very nice and informative presentation.
Thank you, sir.
Yeah, it was a very nice presentation backed up by some very wonderful research studies. So what is your personal experience if I want to know the top 3 indications where you clearly go for this fans instead of the routine RIRS?
So if his patient is pre-stented, we can directly obviously go for fans. And if we are dealing with a stone larger than 20 mm, we should use fans to achieve on-table clearance. And obviously in cases of matrix stone, we cannot clear by routine RIRS. Either we will have to go for PCNL or we should deal it with the fans.
Yeah, that's great. What about the cost implication?
So cost implication is not very much larger than the routine RIRS because access sheets are not costing more than the routine access sheet.
Okay, thank you.
And suction, I think everybody has the suction in their own OTs, and we don't have to use any specialized suction for this.
Dr. Deepesh, one more question.
Any other questions from the house?
Yeah, one question. What pressure do you use for suction? And second, visibility while using suction.
Yes, sir. So we start with the least parameter possible. In our OT, we have suction machine which deals in the Pascal. So 0.1 to 0.2 Pascal we use. And then for the visibility, we'll have to use irrigation along with the suction. While we are doing dusting, we can irrigate. The assistant can have 50 ml syringe who's irrigating continuously. And then suction can be intermittent or continuous as per your liking.
What is
suction with in-place flexible scope?
Yes, sir.
You remove the flexible scope?
No, sir. Suction with in-place flexible scope. And if the fragments are little larger, then we'll have to withdraw the scope and then suck it out. Yes, sir.
What are the chances of
Sir? We can use it both. It depends on if these calyces are collapsing and you are not being able to do RIR, then you'll have to do intermittent. But if the stone is larger and we want to suck the dust out, we can do continuous suctioning also.
What is your experience regarding blockage of the suction and blockage of the channel?
Sir, if the fragment is blockage of the channel will happen when the larger fragments are being suctioned. That we can deal with if we are withdrawing our RIS scope, that fragment can get sucked out. And if it's not being able to suck out, then we'll have to push it back and then lace it.
You have that access sheet.
Yes, sir.
Inside that you are putting the flexi.
Right, sir.
But the blockage usually occurs
between the sheath and the scope.
No, not between the sheath. It occurs where your Y connection is there.
Right, sir.
So at that time, you need to put some wire and to clear it.
We can because it happens with me only once, and I could relieve it with putting a hard end of guide wire.
Yeah, the question of blockage of this flexible scope, I have one experience. My FlexX scope, I did suction through it, and the very small stone got stuck into the lumen of the ureter scope, and by any means we could not take it out. We could never use that scope.
Yes, sir. Durability is an issue.
Yeah.
Yes, sir.
Yeah, when you are doing suction, be careful. And second, right and left, when we start suctioning, sometimes the PCS start bleeding. Because
yes, sir.
It's a high pressure.
Yes, sir.
So we should use only passive suction most of the time, just to open the channel. Otherwise, sometimes we do actively use suction and it start bleeding. And
yes, sir. That is a known problem with the suctioning, sir. But we should use the as minimum suction as possible, as low pressure as possible.
So passive suction is just not putting the suction. The access sheath will itself
suck it out. Yes, sir.
Okay, that's all. Thank you very much. Thanks, you have generated a good discussion. That is what the purpose of this session. So let's move on.